Hello, everyone. Welcome to InterSTEM Talks, episode 8. We hope you guys are all doing well and that your summers are off to a good start. And hopefully, you've had a great 4th of July and just generally and getting some rest during the summer because the past year has been very different, requires a lot of adaptability and persistence and all of that. And so, hopefully, you're just having a chance to spend time with family and get involved in your other interests. One of the things that, or actually the main thing we're going to be doing today in this episode is going to be delving into some uncommon diseases. Actually, that's kind of a little bit stretching the truth. Two of them are more common diseases, but then we'll highlight three other diseases that are really not super common, and one is actually just super rare that some people have never heard of. So we'll be delving into those a little bit for vast majority of the time. And, being that InterSTEM is focused around these things, we hope that this is useful for the summer where you're just exploring in any of the interests that you have. So, by the way, I don't want to forget this at all. I don't want to leave my co-host out. I'm joined by Priyanka today.
My name is Priyanka, and as Andre said, and I'm co-president along with Andre of the Irvine-Tustin Chapter.
Yep. So I myself am excited to start the podcast. So let's just start off with the first disease. We'll kind of be talking about these diseases like individually, I guess. But so basically what we did is ahead of time, we got a chance to get to know these diseases better and explore them almost in a and not like a case study format, but we did our research, and so we just want to convey and forward some of that information to you. So the first disease, honestly, unfortunately, super common, is Alzheimer's and dementia. And the reason that I'm grouping both of them together is because just to start, dementia is the grouping of all symptoms that are related to forgetfulness and difficulty in problem solving and anything that you can kind of think of that comes to mind of dementia and Alzheimer's. Dementia is a grouping of those type of symptoms and behavioral components, but Alzheimer's is a much more specific and most common cause of Alzheimer's. So with that said, though, dementia is not just limited to Alzheimer's disease, of course. There's other forms of dementia, and these forms basically cause dementia. There's vascular dementia, mixed dementia, dementia with Lewy bodies, and frontotemporal dementia. And all of these reside in, you can say, the overarching grouping of dementia terminology. So that's just like an overview of, well, what's the difference between them? What's the structuring? Like, what's the terminology of those two diseases and how are they interconnected? Now, going off of that, Alzheimer's disease is currently known to be caused by the abnormal buildup of proteins in and around brain cells. So I guess it's very similar to the neurological equivalent of cancer in some sense, because instead of cells, there's an abnormal buildup of protein. It's abnormal. It's not intended for the brain to have such a large, massive, rapid accumulation of proteins in the way that it's observed in Alzheimer's disease. So one of the proteins involved is called amyloid. The amyloid deposits basically form these plaques around brain cells. And those plaques are going to be affecting a brain. If you're going to look at an Alzheimer's brain, like you can actually pull up some good pictures online compared to a healthy, kind of like a control variable brain, you'll notice the difference in that there's those plaques around brain cells. And then another difference is there's another protein called tau, and tau, there's deposits of tau which form tangles also around brain cells. So you'll notice both of those things. And then lastly, there'll also be like enlarged ventricles that appear on the brain. So those are some of the things that cause Alzheimer's disease. And those are some of the things that you would probably observe if you were to, I guess, look at this disease in your free time or anything like that. Another thing that I found kind of interesting, or at least relevant to what I'm talking about, is that the risk of Alzheimer's and or I guess vascular dementia is actually, at least so far, what they can observe is that it's increased by different conditions that damage the heart and blood cells. So that can include anything from heart disease and diabetes to like high blood pressure or high cholesterol. And so those are just increased risks, I guess, that can cause or at least aid in the development of Alzheimer's. And so for vascular dementia, that kind of makes sense. There is a link. But Alzheimer's, I thought that was interesting. Another thing that was recently in the news and was one of the main reasons that I wanted to make this a focal point of today's discussion is very recently, as of June 2021, the FDA approved, I might butcher this drug's name, aducanumab, for the treatment of some cases of Alzheimer's disease. Basically, it's the first drug in the US, or from what I can understand, the world, to treat Alzheimer's. It's not a cure, but it targets and removes amyloid plaques. And those were some of the proteins that we were talking about that cause Alzheimer's. So within that drug, there's different substances. Now I have them written down here in front of me. There's donepezil, rivastigimin. I cannot pronounce these. Galantamine. They all prevent an enzyme called. This is actually kind of an important enzyme. So it's called acetylcholinesterase, which is from breaking down acetylcholine. And so when you have acetylcholinesterase, that means that there's going to be a higher concentration of acetylcholine in the brain. And acetylcholine is involved in communication between nerve cells. So if you have that, present, I guess, it can ease some symptoms of Alzheimer's for a while. And although it's not a temporary solution, although it's not a permanent solution, it is I guess, a temporary one that the FDA did approve. The only thing that I guess can be noted here is that the efficacy of it has kind of been questioned recently because it wasn't expected, I guess, necessarily to be approved in the way that it was. So that's, I guess, just some things on treatment. Of course, all these diseases are being mentioned because there's still so much more to do in learning about the diseases and how we can treat them. Another thing that's unfortunate, but prevalent and important in society, in our society, is that's actually a leading cause of death in America. And so it's the sixth leading cause of death, but that ranking has been increasing recently with more just patients unfortunately being diagnosed with Alzheimer's. This doesn't include dementia, but that is also, of course, involved as a major cause of death. And then lastly, this was some history that I found out about Alzheimer's, which I kind of found interesting. I'm normally not a history geek or anything. That's not my forte. But there was a German doctor named Alois Alzheimer, hence its naming. And he first observed what he believed to be a disease or a condition in 1906. So this was not truly recorded or observed until 1906, from what I can understand. And so he described a patient who had memory loss and problems with thinking, problem thinking in particular. And so after the death of the patient, the doctor noticed that parts of the brain were shrunken, and he notated a lot of the things that we're familiar with brains that have Alzheimer's disease. So that was, I guess, like the first observation of it. And I guess that was like the last fact that I thought was interesting related to Alzheimer's and dementia. And so our next disease, actually, I'll let Priyanka take over the next.
So the next disease is a disease called myasthenia, and this is a pretty rare chronic autoimmune neuromuscular disease. And so basically, unfortunately it's very rare. Unfortunately, it can have some pretty devastating effects. And essentially, what this disease it causes is weakness in the skeletal muscles. And what happens is uh, diagnosis of myasthenia isn't unfortunately the easiest. So the longer people go without getting it diagnosed, and the more activity they're exposing themselves to and going through, the condition of the disease essentially worsens as they're continuing to live the normal active life of essentially a normal person. However, by taking periods of rest after a quick diagnosis, this disease can fortunately be reversed to a certain extent. And so essentially going more into what exactly myasthenia causes and it's centered around, the muscles that it affects are responsible for multiple functions, but the most essential ones are obviously breathing and the ones involving any sort of movement of the body, basically the arms and legs. And so what myasthenia gravis does to these is that it attacks certain tendons and joints first, and as a result of certain sometimes chemical differences in the brain, sometimes hormonal differences, and as a result it causes them to worsen, as I stated before, over time. And it essentially gets to the point where you can physically see, for example, in certain patients, drooping of the face because their muscles are just not able to hold up, right? Even if they try to do something as trivial as make a certain expression, their facial muscles just can't support that. And so going a little bit into the name, because it's not a very straightforward name. So the name itself, myasthenia, is not actually the full name of the disease. It's actually Myasthenia gravis, and this is a Latin and Greek name, and in origin it means grave or serious muscle weakness. And so that's, I guess, a little background info about, I guess, the technical meaning of the name. As for a cure to this disease, there is unfortunately no known cure for it, but there are currently lots of therapies in the works. And most cases of myasthenia gravis are, not as horrible. So with therapy, the prognosis for most patients can often be extended significantly. And the available treatments control symptoms of myasthenia gravis, and they also usually allow people to have a pretty high quality of life that a normal person can enjoy. And the prognosis is a normal life expectancy. So going into symptoms and how people can often tell, the onset of the disorder, it tends to usually be pretty sudden, and so symptoms are not, as I stated before, usually immediately recognizable. And the degree of muscle weakness involved can also vary greatly among individuals. So it's also that makes it harder for doctors to also diagnose, because it can vary so much between from patient to patient. However, like I said, as I stated before, one of the biggest symptoms is drooping, usually drooping of one or both eyelids, and this is medically known as ptosis. Weakness of the eye muscles is another symptom, and this is called ocular myasthenia. In this case, sometimes with certain patients, it'll only affect their eyes, and it may not even extend to other parts and muscles of the body. Another symptom is blurred or double vision, known medically as diplopia. Changes in facial expression, difficulty swallowing, impaired speech, known as dysarthria, and general weakness in the arms, fingers, neck, and legs is also another common symptom of myasthenia gravis. So talking about this disease, it's really important to know something specific called a myasthenic crisis. And this is basically a medical emergency, and it can occur any point from the onset of the disease. And it's basically a medical emergency that occurs when the muscles that control your breathing weaken to the point where individuals might require a ventilator to help them breathe. And at this point, obviously, hospitalization is imminent. And it's often triggered by infection, stress, surgery, or any sort of negative reaction to medications that may be involved as part of the treatment plan for their current stage of myasthenia gravis. Approximately 15 to 20% of people who are diagnosed with myasthenia gravis experience at least one myasthenic crisis during the onset of their disease. However, up to about half of the total diagnosed population can experience myasthenic crisis, unfortunately. Certain medications actually have been shown to cause myasthenia gravis. So, these medications are also directly linked to the causation of myasthenic crises as well. So now I want to get a little bit into what causes myasthenia gravis. So essentially, it's basically antibodies, because after all, myasthenia gravis is a autoimmune disease. It's a chronic autoimmune disease, which means that the immune system that is normally responsible for protecting the body attacks itself. As with any other autoimmune disease, the immune system is attacking itself in the attempt to protect foreign organisms from entering. So myasthenia gravis is basically caused by an error in the transmission of nerve impulses to muscles, and it occurs when normal communication between the nerve and the muscle is interrupted at what's called a neuromuscular junction, hence myasthenia gravis being a neuromuscular disease. And a neuromuscular junction is essentially the place where nerve cells connect with the muscles that those nerve cells are responsible for controlling. So neurotransmitters, basically chemicals that neurons or brain cells use to communicate information, are released at these sites as well. And normally when electrical signals or impulses travel down what's called a motor nerve, the endings of these nerves, the nerve endings, they release a neurotransmitter called acetylcholine. And I believe Andre talked about this with Alzheimer's as well. And acetylcholine is responsible for binding to sites called acetylcholine receptors on the muscle. And this binding activates and causes a muscle contraction. So what happens in myasthenia gravis is that antibodies, which are immune proteins produced by the body's immune system, these antibodies basically alter or destroy the acetylcholine receptors at the neuromuscular junction. And what happens, obviously, is that this prevents the muscle from contracting, because like I said, in order for it to contract, the acetylcholine has to attach to the receptor. But in myasthenia gravis, these antibodies that the immune system releases are destroying those receptors. So this is often caused by antibodies that are directly correlated to the acetylcholine receptor itself, but in many cases, antibodies to other proteins such as MuSK or MuSK, muscle-specific kinase protein, can also impair transmission at the neuromuscular junction. It's also important when we're talking about the cause of myasthenia gravis to talk about the thymus gland. The thymus gland controls immune function, and it's often associated with myasthenia gravis, unfortunately. And this gland, just to give a little bit of background, it grows gradually until puberty, and then it gets smaller, and it's basically essentially just replaced by a little chunk of fat. And so throughout our childhood, the thymus plays an important role in the development of the immune system. And so this is where you can see the connection, because it's responsible for producing T lymphocytes, also known as T cells. That's a type of white blood cell that protects the body from various viruses and infections. However, in adults with myasthenia gravis, the thymus gland remains large. Instead of shrinking and being replaced by a fat, it still remains large. And so that's one way actually doctors can diagnose. They can often run x-rays or MRIs to see the thymus gland and look at the size of it. And so people with the disease typically have clusters of immune cells in their thymus gland, and they can develop something called thymomas, which is obviously a tumor on the thymus gland. And thymomas are most often harmless, but they can become cancers. Then that's why I haven't stated it yet, but cancer is also often, cancer of the thymus gland or thymomas is often correlated with myasthenia gravis. Lastly, I do want to touch on how myasthenia gravis is diagnosed, and who is most susceptible to getting myasthenia gravis. So first of all, myasthenia gravis is usually diagnosed by a physical and neurological examination. A physician, after reviewing a patient's medical history, will do a physical examination, and in the neurological examination, they will check muscle strength, because obviously that's most correlated with this disease, the tone of the muscle, coordination, sense of touch, and they will also check the eye movements and any drooping, because that's a common symptom with myasthenia gravis. They'll also perform something called an edrophonium test, and this test basically uses injections of something called edrophonium chloride to briefly relieve weakness in people with myasthenia gravis. And the drug, basically what it does is, this is tied to the cause. It actually blocks the breakdown. Edrophonium chloride blocks the breakdown of acetylcholine, and it temporarily increases the levels of acetylcholine at the neuromuscular junction. And what that essentially, the point of this is for a physician to see and test ocular muscle weakness, or basically muscle weakness of the eyes. Blood tests can also help, because again, they can check for the MuSK antibody, are the anti-MSK antibody, because this is often something that's commonly found in individuals who have been diagnosed with myasthenia gravis. And so physicians can check for that as well. So yeah, that's pretty much all I have to say about this very unfortunate and rare disease, but it's quite interesting disease to think about as well.
Yeah, definitely. Myasthenia gravis, correct? That's the name?
Yes.
Okay.
Yep.
Okay, very interesting. So that was definitely an example of a more rare disease that's still very interesting and relevant. But as another actually as another common disease, there's cerebral palsy that I wanted to focus on a little bit. So just for anyone who didn't know or is not exactly familiar or needs a refresher of this disease, I want to go over the symptoms first. So cerebral palsy kind of has three main targets in terms of like symptom like levels or structures of symptoms. So there's muscular, developmental symptoms, and then you also see speech, some speech impairments. So for in terms of muscular things, there's difficulty walking. Anyone who has cerebral palsy will also have difficulty with any kind of movements with their body that's if they're told to do something difficult. Muscle rigidity, that's another muscular component. There's problems with coordination often, very stiff muscles and overactive reflexes and muscle spasms and paralysis potentially on one side of the body. All of this are like muscular movement related locomotive affecting symptoms. So those are some like I'd say those are one of the most prominent symptoms that you can observe pretty easily in most patients. For developmental symptoms, I was reading online and I kind of didn't like the way they worded this, but let me just say it and explain a little bit of how I dislike it. They said the failure to thrive, um, failure to grow. And so although that's true, it's just very, it's like, it's the equivalent, I think, of horrible bedside manners. But there is difficulty. It is true. There is difficulty in thriving for sure. This disease affects that. Um, there's slow growth, most definitely, and there's speech delay, especially in children. And then that segues into the last set of symptoms, which is speech. There can be speech stuttering often, or just inability to speak. And then there's like a tag on a bunch of other symptoms, some of which are actually very important. So there's like drooling, difficulty swallowing, paralysis, as I mentioned, seizures, actually a very deadly or an unfortunate part of the disease, spastic gait, and teeth grinding. There really are a myriad of symptoms with this disease, but the reason I think I'm kind of familiar with this disease, and one thing I do want to mention as part of, as I'm going through cerebral palsy, is that my uncle has been diagnosed with the disease ever since he was born. And so one of the things you'll notice with cerebral palsy is that it's caused by gene mutations while in the fetus. We really need to do a ton more research on it. There's a lot that needs to be learned and explored about the disease. Of course, it's very difficult to study. That's why we don't know a ton about it. But we do know that there's gene mutations in the fetus. And so as a child, of course, I wasn't alive. It's my uncle. So, but as a child, he actually had a better time in terms of symptoms than he does now. So when he was a child, he was like getting to a point where he could almost walk. As a baby, you can't walk anyways, but age 6, 7, he was like trying to get to the level of walking or understanding people and just being on the borderline of having what normal society would deem as a normal life. But then, as time grew, the disease just kind of not necessarily worsened, but it didn't get better. And that was kind of the problem with, and that's not just his case. That's the case with a lot of cerebral palsy patients. So for him, he can't move. Yeah, he can move his arms. You know, he can pick up grapes and eat some food, but he needs major assistance. He can't, you know, pick up his fork, and you can't feed him pasta properly, just as an example. Um, you know, he's confined to a wheelchair, basically 100% of the time, except if he goes to the bathroom or when he goes to bed. You know, drooling is common. At one point, there was a major risk of seizures, and I wasn't exactly alive during that time period, but they were able to get medication for that to prevent seizures, although that medication is very strong and can bring other side effects that kind of contribute to more difficulty moving and that type of thing. So that's kind of why I got interested in this disease a ton, and why it's always been something I've thought about. So most of this information actually I kind of was already familiar with anyways, just being exposed to someone in my family who had it, or who has it. And actually it's quite remarkable, I guess. I share a birthday with him too. So just that in itself, I guess, has deepened my understanding and connection with someone who's had disease. But anyways, I don't want to get too off track there. The point of that was just connecting some of the symptoms that he had, and to demonstrate what a real life patient, what it might be like for them. You know, you're kind of stripped of a life. It's a very unfortunate disease, and there's a lot of nurses and people doing a lot, the best they can, especially like the parents of these people and the people around them, really trying to do a lot. But in terms of like treatments and cures, as I said, there needs to be a lot done. There are some treatments right now that are being used. Major things are just like therapy, and you know, being that they're not able to have a job or travel around or do anything that we take for granted, being that they're not able to do those things, it's very common. At least this is with my uncle. He goes to like a facility every day. During COVID, my grandparents have had to do it all on their own, but he goes to a facility, and they kind of like, it's half therapy and half just trying to get his mind to work a little bit as much as possible, and just to get him doing things and not to make his life so boring, I guess. But that's one form of treatment, just to kind of ease the symptoms, and even if not, uh, uh, you know, significantly improve the symptoms of the patient, also just to bring a sense that something is that something can be done to others around them as well. But then in addition to that, there's also some medications. These can be like, for example, for muscle relaxant. So there's baclofen, that's one of the drugs. There's tizanidine, and there's diazepam. Those are three drugs used to treat cerebral palsy. I'm just mentioning these drugs because if you're curious to learn more about them, please do look them up. That's where like the most interesting things will likely be. And then the last thing regarding research is that there's a ton of research being done. You know, there's not like recently, from what I understand or what I know, there haven't been breakthroughs, but there's just a ton of forms of research with cerebral palsy. I'm going to name a few so that if you're interested, you can look them up. There's genetics defects research. There's white matter damage research. There's Botox research, which is actually mainly used with children. Constraint-induced therapy, which is a form of therapy, again, mainly for children. And actually, it puts the stronger limb of the child in a cast, and that has an effect on their ability to work, kind of, or at least exercise. And as a child, it's very critical to see if you can try to do as much as possible to prevent future issues with the disease and future symptoms. There's non-government research on cerebral palsy that's separate from the NIH. There's also the March of Dimes, which I participated in like a long time ago. But it's a nonprofit organization that carries out studies aimed at the prevention of premature birth and birth defects. So, that's very correlated and significant to cerebral palsy, of course. So that's a very large organization. There's also other foundations if you're interested, the Cerebral Palsy Research Foundation. And so research, like anything neurological, I guess these days are automatically kind of, how do I say? I feel like there's already so much attention around neurological diseases, but ultimately they require more treatments and they require more cures. And so that's the goal with a disease like cerebral palsy. And I guess the last thing I'll just say, just to leave this disease off on the final note, is that although this disease is common, it's it's just very, it's an unfortunate disease. But despite that, there's a wide array of spectrum for the level of symptoms you could have. You could have cerebral palsy and be able to walk around. It's possible. But then you can also be, as my uncle is completely confined to a wheelchair. So that's the last thing I just wanted to say. There's a wide array, a wide spectrum of symptoms that the patient, I guess, endures. So um, that was a little bit about cerebral palsy. Again, if you're interested in any of those drugs or like research aspects, components, feel free to definitely research that.
Okay, I'll be talking about Miss C, or also known as Miss A, in other cases. And this is basically multi-system inflammatory syndrome. And the C and the A literally is just children and adult. So obviously, because this sorry, not system, syndrome affects both children and adults. Obviously, Miss C being multi-system inflammatory syndrome in children, and Miss A being multi-system inflammatory syndrome in adults. So essentially what this syndrome is it's a rare but very serious, unfortunately, condition that's associated with COVID-19, in which different parts of the body become inflamed, including the heart, lungs, kidney, brain, eyes, skin, and even some gastrointestinal organs, unfortunately. And as I stated, this syndrome affects both children and adults. In the case of Miss C, the case definition for this includes people who are younger than 21 years old, and so that's who we'd consider the patient population. And the case definition or patient population for Miss A or MISA, it includes people who are 21 or older. And so again, because the syndrome is directly associated with COVID-19. Well, based on what we know about this, the best way to take actions to protect yourself from getting both this syndrome is to obviously protect yourself from getting COVID-19. And that currently includes vaccination. I believe if you're not vaccinated, you should definitely get on that. And just general precautions like wearing a mask and social distancing. So I want to talk a little bit about the common signs and symptoms with this. So obviously getting COVID-19 definitely puts you in, for most doctors, they'll see that and they'll say, okay, well, let's test for that. But in terms of actual symptoms, a fever, which is again a symptom of COVID-19 as well, but also bloodshot eyes, chest tightness, pain, diarrhea, really feeling very fatigued, low blood pressure, neck pain, headache, rashes, unexplainable rashes usually, and extreme nausea. In terms of again diagnosis, if this unless you're in a situation where you need to seek emergency care, this might subside with the COVID case itself subsiding. But it's important to know when you need to seek emergency care, and these are the signs that you need to be aware of and seek emergency care for. If somebody's having trouble breathing, they're having persistent chest pain or pressure in the abdominal and chest area, if they're having confusion or the inability to stay awake or wake up, and finally pallid skin tone and pale gray blue colored skin, nail beds, lips, and such. This is obviously not all the symptoms, but this is most of them. And you should definitely seek emergency care for this because at that point, it can be life-threatening. So the main difference between Miss A and Miss C is that Miss C is a lot, unfortunately, more common than Miss A. However, in terms of outcomes for both, the outcomes for Miss A are actually going to be more severe than Miss C in most cases because simply because of the differences with the immune systems of adults in comparison to those of children, as well as adults being more likely to have other underlying medical conditions that might make it harder for their body to be able to fight against the Miss A. So I want to get into a little bit more about sort of what specifically can be done to diagnose Miss C and Miss A. And so basically what doctors will do is they will, run something called a RT-PCR or antigen test. And this is the most common mode of diagnosis. And it's also their way of detecting SARS-CoV-2 or COVID as well. Um, they can also do serologic testing. Serologic testing, however, it is important for serologic testing to be done before they start administering immunoglobulin for the SARS-CoV-2 antigen test or any other sort of antibody test of sort. And in terms of other possible evaluations they can do to try to test for it, they can also run an echocardiogram, an electrocardiogram, cardiac enzyme or troponin, or AB type natriuretic peptide, or also known as a BNP. Now I want to talk about the treatment. Unfortunately, there's not a lot more I can say after talking about the treatment because, with COVID being something we're currently battling, the CDC and the WHO, as well as doctors and other medical companies in general, haven't had a lot of time to look into the exact causes of Miss A and Miss C, other than the fact that it is directly correlated with the onset of COVID-19 in a patient. So as for treatment, there have really been no studies comparing clinical efficacy of various treatment options. So treatments have primarily consisted of supportive care and directed care against the underlying inflammatory process. And this is, again, what kind of causes Miss A and Miss C. Supportive measures and main treatment therapies include fluid resuscitation, inotropic support, respiratory support, and in certain rare and very extreme cases, extracorporeal membranous oxygenation, also known as ECMO. And because this is an inflammatory process that causes Miss A, they also treat some patients with anti-inflammatory measures like frequent use of steroids and IVIG, which is basically intravenous immunoglobulin, which is also used in general COVID treatment as well. Thrombotic prophylaxis is also used because Miss C, so basically the case in children, is often hypercoagulable. So prophylaxis usually helps with any kind of hypercoagulable disease. And the American College of Rheumatology has also developed additional guidance for pediatric patients, just in terms of taking extra care and not giving them certain medications like aspirin because it can cause potential future coronary issues in them. Thank you. That's pretty much all I have to say. It's pretty interesting to look at. I think it's unfortunate we don't know a lot about the exact causes, but I hope that as the pandemic continues to subside and we continue to battle it and overcome it, I hope that we can get over this too, and we can look into Miss A and Miss C so we can reduce the number of cases.
Definitely developing disease. Yeah. Okay, so far we've gone over MISC, multi-system inflammatory syndrome. We've gone over cerebral palsy, and then we did the other two diseases at the beginning. And so the last one I want to do is it's called Alice in Wonderland syndrome. You might have heard of it, you may have not, but it's a very rare or actually just generally pretty rare neurological disorder that is characterized by distortions of visual perception, the body image, and generally the experience of time. So In essence, people can see things smaller than they are, or they can feel like their body is larger, or again, smaller. It can alter in any size. And then there's a bunch of other symptoms that also coincide with the Alice in Wonderland syndrome. And so those can also be experienced. Some of those are like migraines, nausea, dizziness, agitation, and other less frequent ones include like memory loss, actually, emotional instability, loss of limb control, sound sensations, like lingering sound sensations. So you can clearly see a lot of these symptoms are very related to neurological symptoms that you might expect for a neurological syndrome to have. In regards to the causes of this disease, the abbreviation would be AIWS. The causes for AWIS are not really known, but generally what can contribute, or what, like, these are like things that you might observe and then you might get AIWS, is like a typical migraine, a temporal lobe epilepsy, brain tumors, psychoactive drugs of Epstein-Barr virus infections. That's a mouthful, but definitely look that up if you're interested. It's pretty interesting. I don't have the time in the podcast to go through that in depth, but ultimately there's no proven or effective treatment yet for this rare syndrome. However, just in terms of a treatment plan that can be done as much as possible by medical professionals, that plan will consist of migraine prophylaxis and migraine diet. So centered around migraine, like ways of treating migraine, because those are the symptoms that this disease or disorder, or whatever you want to terminize it as, that's what they revolve around. The most interesting thing about this disease that gives it its name is from, as the author of Alice's Adventures in Wonderland, Lewis Carroll was the actor. I mean, not wait, not the actor. He was the author of the book, and so people kind of, they don't have direct evidence, but it is very possible that he was influenced by his own experience of migraine in writing the book. There's a moment when Alice finds a bottle labeled "Drink Me," and when she does that, she shrinks to less than 8 foot tall, and almost like instantaneously, she consumes a cake that causes her to grow very, very tall, and then her head kind of like hits the ceiling. So that's something that genuinely, as like a form of I guess hallucination, or something that you would feel. You wouldn't actually increase or anything in terms of height, but that's something that the patient might feel like very intensely, and people think that might have been influenced by Carol's own experiences, kind of, and including that in the book. So that's where it gets its name, Alice in Wonderland syndrome. Ultimately, that actually wraps up all the syndromes there, or syndromes, diseases, disorders, impairments. We hope that this provided a lot of just exposure or general insight to maybe spark interest in one of these diseases, because if you are, then I would say the next steps, all of us being high school students that want to learn more and are really hopefully fascinated by this kind of stuff, at least if you're into medicine or biology and those relating subjects, then the next step is to take this to research or other programs. So if you're really, really interested in cerebral palsy, well, then just like start watching some videos on research that's being conducted, or read some articles, and then dive a little deeper. Maybe next summer you can find a program that goes into neurological disorders, or maybe it's revolving around autoimmune diseases. So the purpose of this podcast really was to just give some insights into some of the routes that you could take, and then allow you or just give you, I guess, a little bit of a drive to move forward, I guess, with that. We hope you guys really did enjoy, and we will try to film the next podcast episode within 2 to 3 weeks. So definitely stay tuned for that. Thank you all for tuning into past podcast episodes. We have so far 7 past episodes. This makes it 8. So you can go check them out on Spotify, Google, Anchor.fm, InterSTEM Talks. You can join the Discord server, all of that good stuff that's, of course, available to you. And if you live in Irvine-Tustin, please consider joining our chapter. We do blogging, mentorship, of course, podcasting, and other opportunities that are related to InterSTEM. So thank you, everybody, and we hope to see you at the next podcast.
Thank you.
Bye-bye.